Well, everybody, welcome to another week of what we find to be an incredibly exciting, interactive, somewhat entertaining, but 95% informative show that we do from Maiden Lane Medical every week called Women's Health Weekly. We love doing this. We love having guests on. Dr. Davison, now we're on what, our fourth week doing this?
I think so.
Yeah, it's awesome, and we plan to continue doing it. Um, so I hope everybody is enjoying their somewhat pseudo spring. It is here to come. I saw on the Weather Channel today something about a snow bomb over the weekend. We're hoping that whatever a snow bomb means, I have absolutely no idea. We're hoping that doesn't happen. But who knows these days with all the craziness that everything else seems a little bit nutty. So snow bomb is a definite possibility. Um, Today we have our guest, Dr. Anate Brauer, who is an expert in fertility, an expert in infertility,
Nice.
and she works here in New York City, which is where we're broadcasting from today. And I know we have lots of amazing people joining us from all over the world, which we absolutely love. And we love your questions and we love all of the exciting stuff that you bring to us and all the exciting perspectives. But Dr. Anate Brauer is with Shady Grove Fertility here in New York City. And we're hoping that we bring some light, some information, some happiness, some hope to women who are curious about fertility, for women who are curious about potential issues associated with infertility. And we do this in the spirit of Mother's Day. So we don't broadcast on the weekends, and I think we'd get about one viewer if we actually did it on Mother's Day, and that one viewer would be my mother. She would be the only one who would watch if we actually did it on Mother's Day, and probably Jeanette's, family would be on there. So it'll be all sorts of folks that like us, and everyone else would say, "Nah, I'm eating breakfast in bed, and I'm not. I don't want to have anything to do with this today." So, um, just also by way of introduction, you guys have met Dr. Janette Davison already. Dr. Davison is a top pelvic surgeon, gynecologist here in our practice at Maiden Lane Medical in New York City. So we really have a fantastic crew of knowledge. We have a fantastic subject today, and we're looking forward to getting started. So one of the things I always say at the outset, I'll give you two items today, and then we'll really get cooking. The first is please subscribe to our YouTube channel. We love to hear your feedback. We love to hear your questions. If you don't get your question answered online today, please ask us the question offline and we can refer it to Dr. Brauer and we can get those questions answered and make sure things move for you in the right direction. We have lots of exciting clips and highlights and shorter videos coming up. I understand that nobody wants to sit and rewatch one of our 40-minute videos. So we're breaking them down into highlight reels, and we hope those will suit you a little bit better. So let's just jump into it. Let's talk about just the basics. Tell me, Dr. Brauer. Dr. Brauer, where are you from originally?
So I'm actually originally from Israel. I moved to Memphis, Tennessee at age 11, and then kind of winded my way through, went to undergrad in Kansas, of all places, and did a master's in Philadelphia, went to med school in DC, and then finally landed in New York for all of my training, for my OBGYN training and my infertility fellowship training at Cornell. And for the last 6 years or so, I've been practicing out in Westchester where I live. And this fall came together with Shady Grove Fertility, which is a very large fertility center that has 7 other regions, and we decided to open in New York. So I'm back in the city. I'm not originally from New York, but I just live and die for this city, and I'm happy to be here.
So my life's not nearly as exciting as that. My life doesn't even come close to that. I'm from the New York burbs, went to school in Buffalo and Washington, D.C., and now I'm back in the city. Dr. Davison, how about you?
Same. I'm boring. I grew up in Jersey. I went to school up in Ithaca, and then I did all of my med school and training in New York City for the past 15 years or so.
So
Boring.
we're pretty vanilla, but you're not. So let's talk about fertility.
Yeah.
Let's talk about I don't know what fertility is.
Sure.
And I bet a lot of people out there also don't know what fertility is. So just go ahead and talk to me. Tell me what fertility is.
Sure. So first, I just want to, send a message, as Dr. Levy said, of hope to everyone out there on Mother's Day, whether you're struggling to become a mom. The beauty of what I do is that for anyone walking in the door, man, woman, have eggs, don't have eggs, have sperm, don't have sperm, have a uterus, don't have a uterus, anyone walking in, there's now a way to build you a family. And so if that's something that's very important to you in your life, don't give up on it. So that's the first thing I want to say. So the definition of infertility is basically 12 months of trying to conceive without success. That's kind of the basic definition for you. Go ahead.
Is that for everybody? Is that across the board? Like 12 months, not able to get pregnant. That's it. You're infertile.
Yeah. So that's the traditional definition of infertility. Of course, the second question, most important question is, well, when should I seek help? And that varies depending on age. So, if you're under 35, most women will try for 12 months or so before seeking help. If you're over 35, if you've been trying for 6 months or more, we would recommend that you see somebody or at least talk to your OBGYN about it. And a question I get very frequently is, well, when's the right time to see a fertility expert? And my answer to that is anytime, right? So, I see patients all the time who are in their 20s even, who just started trying to conceive, and they've been trying for 6 months, let's say, and they just want to make sure everything's okay. And I'll talk a little bit about the workup in a minute. And there's nothing wrong with that. I mean, there's nothing wrong with having a consult with someone if you've had concerns about your reproductive health, just to kind of go over the basics of, first of all, how do you conceive? How do you optimize timing of natural conception? And just to make sure everything is kind of normally happening. Usually these consults are covered by insurance. And so there's really no risk. I mean, a lot of people have this misconception that just by way of seeing a fertility expert, you're going to be pushed directly into treatment. But I actually see a lot of patients who I just counsel them on, optimizing natural fertility, check to make sure everything's kind of working, and then tell them, go try on your own for another 6 months. If you're not pregnant, you're hooked in. You know who to come back and see.
So I just want to hit some of those points. Those are great.
Sure.
Those are great points, and I think Dr. Davison and I also see this similar group of patients in the office, because Dr. Davison and I deal primarily with one of the issues that we're going to hit later. That is one of the major causes of infertility, which is endometriosis, which we'll talk about a little bit later. But just so I want to go back to your definition.
Yep.
So if I'm able to, not me, because obviously I would never get pregnant, right? Is that correct?
Yes.
Yeah, okay, good. I just wanted to make sure. Yeah, I just wanted to make sure we're having this conversation, and I may say, well, if I was, but very clearly I can't get pregnant, so that's not even part of the conversation. So if someone can get pregnant within 12 months, and as you define, sort of 12 months before you're 35, 6 months after you're 35, you've got that sort of separation. I'd like to hit on why that's an important separation as well. But so then they're fertile. Or as a term, I heard an interesting term a while ago, reproductively efficient. Who gave me that term? It was Jamie Griffo, which I thought was really, really an interesting sort of like, well, you're reproductive. Dr. Griffo's a well-known reproductive endocrinologist here in the city. So it was sort of an interesting term. Okay, so someone is able to get pregnant within 12 months before the age of 35, and within 6 months after the age of 35, they don't have fertility issues.
Correct, except for that.
Right? There's an exception to everything, isn't there?
Right. So, under the umbrella of infertility are a lot of different diagnoses. One of those is recurrent pregnancy loss. So it's not just the ability to become pregnant, but it's the ability to, carry a pregnancy to term. I would also include that under the definition.
Okay, that's great. And I'd love to we should definitely hit recurrent pregnancy loss, because Dr. Davison, is that something that you see fairly frequently in the office? And
I do. Both speaking to the first question, just to go back for a second, I agree with this, just the comment of when to refer patients. I mean, I think even if the conversation sometimes is just coming up in the office, I think that's even reason enough sometimes to refer patients who have a lot of questions, we do see a specific subset of patients. So this chronic pelvic pain endometriosis population, many of them, some of them I'll be operating on, others will be undergoing medical management, but we do talk about fertility, and many of those 20-year-olds I actually will refer for a consultation. I'm sure we'll touch on this, but now that we also have egg freezing abilities, it's really relevant to identify these concerns and address them and really listen to them, because even if it's just for a consultation, there's so much valuable information, there's so much reassurance that comes from those visits. I think we start these consultations much earlier than we used to when I first started practicing. To speak to the recurrent pregnancy loss conversation, that comes up as well. And even though a lot of the components of the workup, of course, we can do, I think that it's just a much more holistic, thorough approach to refer a lot of those patients out. So really, we utilize this relationship with our infertility specialists so liberally, which is great.
So you guys are throwing around some big words. And I think it's important for us to get the patients who are, and the people who are out there who are in our YouTube audience and who are already asking questions to be able to kind of understand some of the things we're talking about. So I really want to flesh out and unpack some of the information: recurrent pregnancy loss, endometriosis, referrals left and right. Let's make it clear to them and give them some basis of understanding. So I have a set of questions for Dr. Brauer, but it looks like you were about to say something, so I really want to hear what's on your mind.
No, I just, just to kind of like lay the groundwork, I think, because when I say the word referral, I mean, or when Dr. Davison said the word referral, she means, that you see your general OBGYN and they can either do the workup or all the tests that I'll tell you about in a second themselves, and then send you to the fertility specialist. So that would mean to refer you to the fertility specialist. Or, if there's no issues with insurance or anything like that, and you want to have like an hour of time to delve into these specific topics, then you can just go directly to a fertility doctor. So, if you look at kind of basic testing of what needs to be done, and OBGYN can do it. I'm sure you guys do it all the time. I mean, when we look at, what do you need to make a baby, right? We want normal sperm, open fallopian tubes, a normal uterus to implant, and normal ovaries with a normal quantity and quality of eggs. And there's very simple ways to kind of test all of these things. I don't know if you want me to go into
We're definitely going to get into the testing in a second. Okay. That's an exciting topic. That's an exciting topic. So if you're essentially, now, Dr. Brauer, correct me if I'm wrong. If you're at your general gynecologist's office and you say, I am 32 years old, my partner and I have been trying for 14 months, we understand the concept, and I'm going to give you 2 minutes to explain the concept of timed conception or timed intercourse. We understand that concept. We've been doing it. I still can't get pregnant. What are the things that obstetrician, gynecologist, generalist has to do in order to properly evaluate that? What should the patients expect to be done? And I always say, if your doctor's not doing X, Y, or Z, go find a new doctor.
Yep.
Right. So just if you wouldn't mind, I'm gonna get you on 2 things here. One, the concept of timed intercourse, timed conception, and 2, what are in that scenario that I just presented with a woman who's maybe 32, has been trying for a very long time, same partner, and she's unable to conceive. What are the basics that a woman should expect their doctor to do?
Yes. Okay. So I'll talk about timed intercourse first. So to understand anything we do, we could understand just how a regular cycle works. So let's take, everyone's individual, but in a textbook, when I say cycle, I mean period to period. So if you looked in a textbook cycle from period to period is about 28 days. Some women have 21 days from period to period, some have 40 days, and that's okay. But let's take 28 days. So when you get a period, you start off with all these little resting eggs in the ovary, and they're housed in little sacs of fluid called follicles. And your brain makes a hormone. It's called FSH, follicle stimulating hormone, that stimulates one of these follicles, one of these eggs to grow. And so over the first, let's say 14 days of your cycle, meaning since your period, this egg is growing and maturing, and it's making estrogen, which is another hormone that our body makes. And eventually, once it reaches a mature state, it ovulates, meaning it triggers our body to make another hormone. The other hormone is called LH, that basically leads to ovulation, which means that, by the way, LH is what you're checking for in those ovulation kits, if you've ever used those. And 24 to 40 hours after that surge of that LH, the egg leaves the ovary, it ovulates, and now it can meet a sperm. Your body makes another hormone called progesterone that basically stabilizes the lining of the uterus and makes it prepare for implantation. And that embryo is then able to implant. If you don't get an implantation, the progesterone goes away and you get a period. And that's kind of what happens every month. As far as what your OBGYN, let's say you're not, you can either use ovulation kits where you're trying to time things specifically, right? Or if you have a pretty regular cycle, like 28 to 30 days, you know kind of when you're going to ovulate, right? It's right in the middle of that cycle. So I always tell patients, count to day, 10 of your cycle. So cycle day 1 is the first day of full flow of your period. Count 10 days from that and have intercourse every other day from day 10 to 16, let's say. And if your cycle is perfectly normal, you should be getting the timing right. Now, let's say you've been doing that for, as you said in this couple's case, 14 months, and you talk to your OBGYN about it. A good OBGYN would start doing some kind of a workup. So easy things you can do off the bat, check the sperm, right? We always forget about the sperm. As women, we always blame ourselves for not getting pregnant. But at the end of the day, the men are like half the battle here, right? So
exactly half the battle, right?
Yeah.
So far as I recall.
So a semen analysis is something that's very easy to do. It's non-invasive. It's usually covered by insurance. Even if it isn't, it's not expensive. And so just kind of check that box. You can also do a test called they should be talking to you about a test called an HSG, a hysterosalpingogram, which is a radiologic test that looks at the uterus and the tubes. It makes sure that your uterus has a normal contour and that your fallopian tubes are open. The fallopian tubes are where egg and sperm meet. So that's why they're very important. And it's basically a test whereby we put in a little catheter and we infuse the uterus with dye, and we take x-ray pictures of the dye filling the uterus and coming out of the tubes. And then we have to evaluate your ovaries. So with ovaries, we worry about two things, right? Egg quantity and egg quality. So egg quantity, we call that ovarian reserve. You may hear that term sometimes. And that's just how many eggs do you have left? Because women are born with a certain subset of eggs. We have 6 to 7 million eggs when we're in our mom's uterus. By the time we're born, we have about 1 million eggs. By the time we hit puberty, we have about 300,000 eggs. And every month when you ovulate, when that one egg that's chosen to ovulate becomes mature, the rest of them kind of die off. So there's markers that you can look at to see where you are on that ovarian reserve spectrum. And one of the tests that your OBGYN might send is one of those markers. It's called AMH, anti-Mullerian hormone. It's a blood test. You get it back in about 5 to 7 days. And it's basically a marker of how many resting eggs you have. So the more eggs you have, the more AMH you make. That's purely a quantitative marker. It doesn't tell me anything about your chances of pregnancy in nature. And the other part of the equation is egg quality, which is genetics of the eggs, right? So as we get older, not only do we lose eggs, but the eggs that we retain age, they get more and more DNA mutations, which leads to an egg with the wrong number of chromosomes, which either won't fertilize, will fertilize and not implant, or will fertilize, implant, and lead to a miscarriage. And while there's no blood test we can do on you to tell you what the quality of your eggs are, we know from testing hundreds of thousands of embryos at different age groups through IVF that at 30, around half your eggs are genetically abnormal. By 35, it's about 55 to 60%, and by 40, it's about 90%. And that's where the timelines come into play. That if you're over 35 and you've been trying for, even less than a year, maybe you should start to think about seeing somebody.
I think that's the question. That's the question on a lot of people's mind, based on the questions we're getting here. Yeah, so there's an it's not a myth. It's not a myth. There's a biological decline in the egg quality that can lead to two major issues. One, inability to get pregnant at all, and the second one, an abnormal embryo.
Yes.
So, okay, I'm glad. Is that, Dr. Davison, are those the set of tests you normally order when you see a patient in that scenario? Is there anything else?
No, that's pretty much it. Yeah. That's assuming they have a regular menstrual cycle, which was the scenario we talked about. Obviously, if there's something else, such as an irregular menstrual cycle, I'm testing, various other hormones to assess things like polycystic ovarian syndrome, which would be a problem with ovulation. So assuming that there's no problem with the cycle length, then, right, you're checking mostly the structural things and then the quantity of eggs. And then we get into a different set of tests when you're assessing for the actual presence of ovulation.
Got it.
Correct.
So that's an awesome basis. Like, where do people get that information? Right here from the experts, Maiden Lane Medical, Dr. Anate Brauer, Dr. Janette Davison. Fantastic. That's great. And just to add again, Dr. Brauer is joining us from New York, Shady Fertility, on our YouTube channel, maidenlanemedical.com. So, all right, so let's jump into the next sort of section. I think I'm totally normal. Again, I understand I can't get pregnant. So it's me as if I were a woman. I think I'm totally normal, Dr. Brauer. I'm 28 years old. I've been married for a couple of years. We're ready to start a family. I don't know whether or not I have a fertility problem. I'm not particularly worried about it. What are the things, if any, maybe there's just nothing, but what are the things, if any, other than timed intercourse that you described earlier, what are the things, if any, that I can do, either diet or lifestyle or exercise, that would lend themselves towards improving my chances of getting pregnant and if so, getting pregnant even faster?
Absolutely. So there are definitely lifestyle and environmental implications for conception. Don't smoke. Smoking is one of the worst things for fertility for many different reasons. So first, other than not being healthy for you, obviously, but from a fertility perspective.
You don't recommend smoking in general.
No, I don't recommend in general. But if this is what's going to motivate you, smoking actually, so our fallopian tubes have little tubules in them that help move egg and sperm towards each other. And that's what's required for fertilization. So just like, if you're a smoker and you cough a lot or you get a lot of respiratory infections, it's because the smoke is paralyzing these same kind of tubules in your breathing tubes. And those are the same structures that you have in your fallopian tube. So smoke is doing the same thing to them. So that's like off the bat, you're definitely, infertility can be due just to smoking alone. We also see that women who smoke over time tend to have a lower, faster decline in their ovarian reserve. So smoking can, destroy eggs, not only quantity, but also quality, because smoking can affect DNA. DNA is what all of our cells are made of, inclusive of eggs. So obviously smoking. Excessive alcohol use, I'm someone who's like, everything in moderation, even in my patients who are currently cycling, not after you have an embryo transfer, not after you have a potential pregnancy, but anything kind of leading up to that. It's okay to have a glass of wine here or there, but excessive, alcohol use definitely has effect on both egg and sperm. By the way, smoking has an effect on both egg and sperm, because that same tubule, the same structure of the tubules in your tubes and your breathing tubes also is on the tail of the sperm. So it can decrease sperm motility as well. So excessive alcohol use, smoking, drug use, obviously can have an impact. Healthy diet and lifestyle. So we know that obesity has a negative impact, not only on fertility, but it can also increase miscarriage rates. So diet and exercise are obviously very important. And specifically in the subset that Dr. Davison mentioned, something called PCOS, I don't know if we'll talk about it later, but women with PCOS have irregular cycles. And part of the reason for that is when I talked about the fact that, the trigger for your brain to tell the ovary to grow an egg is that at the beginning of your cycle, your estrogen should be nice and low. What happens in women with PCOS who tend to have these kind of irregular cycles is that they have a lot of estrogen running around. Estrogen's made in two cell types in the body. It's made in the ovaries and it's made in fat cells. Okay, so if you have a higher BMI and more fat cells that are making more estrogen, the brain kind of sees that estrogen and thinks you have an egg growing and thinks that it doesn't have to grow an egg, and then becomes really inefficient at growing an egg and ovulating it. And that's what makes it so difficult for those patients to get pregnant. So we see in women with PCOS and even without PCOS that weight shifts or weight swings definitely affect cycles. So, kind of staying within a normal range of a BMI, diet and exercise. Prenatal vitamins are very important for anyone trying to conceive, specifically folic acid, which prevents neural tube defects, which are defects of the spine, things like spina bifida. We want women to be on the prenatal vitamins, not when they get pregnant, but actually 3 months before conception is something that's very helpful. Other things that have been studied in the fertility world are the importance of vitamin D. So we check all of our patients walking through the door. We always check vitamin D on them. If their vitamin D is low, we have a repletion protocol. Other supplements like coenzyme Q10, which is an enzyme that's actually important in energy production in cells. So we have this naturally occurring enzyme in our cells. There's been more and more literature on CoQ10 and its importance in reproduction. A lot of it comes from mice studies, so I'm not so sold on it, but CoQ10 is good for you anyway. It's good for your cardiovascular health. A lot of people are on it for that, and it may help in reproduction. So I always recommend that as well. And other environmental things are, things like trying to reduce refined sugars, trying to reduce processed foods. And there's actually a lot of data on plastics, specifically.
Specifically, don't eat them.
Don't eat them, yeah. But
Okay.
it's so hard. It's hard to get rid of plastics in your life.
Sure.
But plastics definitely have an effect potentially on efficiency to pregnancy. So, all of those things are kind of natural things you can do to try to improve outcomes in a natural setting.
That's pretty comprehensive. That's great. I mean, I think that there are a lot of women out there receiving information that is very confusing, and that there's a lot of information on the internet that at the very minimum is not just confusing, but actually false. There's
Yes.
actually information that you could look at on, I'm sure, any number of websites that will tell you what they believe, but is not supported by real evidence or real research studies. And that's why we have experts on with us, so that we can offer you the best possible set of information. So that was great. Okay, so I think you answered this question earlier, and it's something that comes up all the time. And I think Dr. Davison and I, in our gynecology office, see this frequently enough, and I bet you see it all the time. When I was a resident, I learned that men are responsible for a significant amount of couples' infertility. How much are the guys responsible for in general, and what do you do to evaluate that? I think you mentioned earlier, but let's just do a quick review of that.
Sure. So male factor infertility accounts for about 30%, about a third of infertility that we see. Usually when, this is diagnosed on a semen analysis. So a semen analysis is the first test for a man to do. We look at three things. And first of all, you want to make sure you do a semen analysis at an andrology lab that actually knows how to do a comprehensive semen analysis. That's very important, right? The quality of your test. So we look at three things. We look at quantity of sperm. So how many millions of sperm do you have in that sample? Because yes, men make millions of sperm every day. Motility of that sperm. So how are the tails moving? And morphology of the sperm. How are the heads shaped? Because the heads have to be shaped a certain way and the tails moving a certain way to be able to penetrate, to be able to penetrate an egg. So if we see that any of those parameters are off, the first thing we do is just repeat the semen analysis, right? Because sometimes it's just a fluke. We want to make sure that you haven't ejaculated in 2 to 3 days. So, and a lot of things can affect sperm, like if you're sick, if you have a cold, if you're tired, if you drink too much the night before. I mean, all these things can affect sperm. So we always do 2 studies if the first one isn't good. And in my patients, if they have low parameters, I usually send them to a reproductive urologist. And that's because quality of sperm can be indicative of, other things going on in the body, right? So, sometimes things like testicular cancer can first present as abnormalities in a semen analysis, things like that. It can be indicative of various processes or diabetes, other things. So that's the first thing I do. And what usually those male reproductive urologists do is they do a testicular ultrasound. They do hormonal profiles, right? So there's different, just like women, right? When women have low ovarian reserve or have a low egg count, we want to know why. We want to know, is it a process that's going on in their brain because their brain makes hormones to tell their ovary to grow eggs? Or is it a process going on in their general body? Or is it a process at the level of the ovary, right? So for men, it's the same thing. Is it a process going on in their brain that they're not making the right hormones that are telling the testicles to make sperm? Or is it a process on the level of the testicle where they're just not making sperm? So those urologists usually do a hormone profile, and they also do a genetic profile. So, a lot of times men have very, very low sperm counts because there's deletions in the Y chromosome. So a chromosome, women have 46 chromosomes with 2 X's, and men have an X and a Y. And it's that Y chromosome that tells a man's body basically to make sperm. So you can have abnormalities in that chromosome, and a urologist would be able to, and we send that testing sometimes up front so that the urologist will have it, but it's important to test for those. They're called microdeletions.
So we leave a lot of that testing to the guy doctors, right? The urologists.
We do. I mean, I usually will send at least the genetics because that takes a little time to come back. And then I'll send them off to, urology to do the testicular ultrasound and the physical exam and the hormonal profiles. But usually a male, and make sure it's a reproductive urologist because, there's a lot of urologists out there, obviously, but not all of them deal specifically with reproduction. So I think that's important as well.
So while Dr. Davison and I have said this on every single telecast, we're not here to buy, sell, promote, recommend, but we do happen to have a reproductive urologist who's fellowship trained at Maiden Lane Medical, a guy named Dave Kaufman. So if you need that service, then that's there. But certainly you could go to any number of reproductive urologists anywhere in the world. That's great. Dr. Davison, do you have anything to add to that? And even the part about what to do so let me actually ask you a question. Maybe Dr. Davison can answer this, or either one of you can answer it. Specifically with timed intercourse and getting pregnant, is it true that after ejaculation that it's better for the woman to kind of like elevate her hips or like lie on her, like kind of like get her hips above her head kind of thing to have the ejaculate stay inside her vagina? Is that a myth, or is that just or is it not a myth? What do you guys think?
I have my thoughts, but I'll let Dr. Davison go first.
I was going to say, well, in terms of IUI, so intrauterine insemination, there is, well, you can speak probably better to this. I'm just, there is, some offices that follow a protocol to keep women sort of laying down for at least 20 minutes. And that's what we used to do in our residency training, at least. But we don't usually tell people that for spontaneous timed intercourse.
Yeah. So there's no data to support that, putting your hips up or your legs up or any of that is going to help. Sperm is actually so fast, and it's to the tubes in about 5 minutes or so. So, sorry.
Really?
Yeah, really.
That's like this much distance. That's so funny. The thing's this, you can't even see it. How does it go that fast?
It just goes that fast. Have you ever seen them under a microscope?
Yeah, I have, but that's,
So it's interesting. For our IUIs, we have them rest for 10 minutes. And that's really, I mean, does it really increase the outcome? Maybe not, but there's no risk to it, right? So
Exactly,
same thing
yeah.
with intercourse. I mean, you know, I wouldn't wait longer than 10 or 15 minutes after intercourse, because then you're going to end up potentially with a urinary tract infection if you don't empty your bladder, which is a whole other discussion. But you know, resting there for 10 minutes or 15 minutes isn't gonna hurt anything, certainly. So, but I don't think you need to like be upside down or doing a headstand unless you're into that. I mean, so.
Dr. Davison, let's make sure we do a weekly telecast soon. We have dermatology, skin stuff coming up. We've all sorts of interesting stuff coming up. Let's make sure we do a telecast soon on recurrent urinary tract infections.
That's a great idea.
That's definitely a topic we should hit.
Yeah.
So, Dr. Brauer, let me shift gears just a little bit and go into some of the treatment scenarios or treatment issues. And what I really don't want to do is I don't want to focus on like the esoteric kind of rare situations we see, or the you know, the minutia of the ethical issues. There's a ton to talk about when it comes to infertility. It's such a rich topic. What I'd really like to talk about is sort of some of the basics of treatment. My guess is some of these kids are in the background. We're all working from home.
Yeah.
Some of these kids
Sorry
are
about
banging
that.
in the back. That's
Clean.
That's perfectly
Sorry
fine.
about that.
My kids are probably about to run down the hallway screaming something. So let's just talk about some of the basics of treatment associated with just the general most common scenarios you see in the office.
Absolutely. So the most common reason for infertility is unexplained infertility, right? Which is a very frustrating, you know, about 40% of my patients have unexplained infertility, and it's very frustrating for the patient. It's very frustrating for the doctor, right? Because you can't give the patient an answer. But we do have, you know, weapons in our arsenal to treat that. So, you know, if you've been trying for 6 to 12 months, depending on your age, and you've had the whole workup done and everything is normal, the sperm is normal, the tubes are normal, you know, you have a normal reserve, everything's fine, then you're kind of put in this category of unexplained infertility. And the first step to treatment is doing something called a medicated IUI, so intrauterine insemination. Usually we do this kind of cycle with some kind of oral medication. One of the most common ones is called Clomid, clomiphene citrate. And basically Clomid is a medication that you take for 5 days. So you call your doctor with your period. This is how we do it anyway. You call your doctor with your period, you come in for a baseline ultrasound to make sure the ovaries look normal and the uterus looks fine, you don't have any cysts or anything like that. You take the Clomid from cycle days 3 through 7, so 5 days. And what Clomid does is it masks your brain from seeing that estrogen that I talked about earlier. So it makes your brain work even harder to grow an egg. It makes your brain make more of that FSH, that follicle stimulating hormone, that tells the ovary to grow an egg, with the thinking of, if I have more than one egg growing, so let's say 2 eggs or 3 eggs, I'm going to increase my chances of pregnancy. So you take it for 5 days, and then we monitor you with ultrasound and blood work. We bring you back about a week later. We do an ultrasound, and we can actually measure the follicles, right? Those sacs of fluid that house eggs. And we know that when a follicle gets to be a certain size, the egg inside should be mature. We trigger the ovulation, and we schedule an insemination of sperm, which means we take the sperm sample, we wash it, we concentrate the most motile sperm, put it in a catheter, and we put in a speculum and put it through the cervix into the uterus. It's about a 5-minute procedure. It's non-invasive. It happens in the office. And then you rest for 10 minutes afterwards, and then you go along your way. So that's kind of the first step of treatment. Now, in our unexplained infertility patients, let's say you've done that, you know, 3 times. You have to give it a chance. Every cycle that you do that, you have about a 10% chance of pregnancy, which sounds totally abysmal, but you have to put it in the context of unexplained infertility. And those patients with a diagnosis of unexplained infertility now have about a 3% chance per month of achieving a pregnancy. So you're taking it from 3% to 10%, which isn't amazing. But again, a 25-year-old at the peak of her fertility in life has about a 15 to 20% chance per month of achieving a pregnancy. So humans are just really inefficient at reproduction. And so every little bit gets you back to that, baseline that you should be at in nature, which is about 10 to 15%, depending on your age. So that's a Clomid IUI or a medicated IUI. Let's say you do it 3 times and you're not successful. You sit down with your doctor, we go over how the cycles went, and then that's a discussion point of, okay, do we want to keep doing the IUIs or do we want to get more aggressive with something like IVF, which, is a whole other, I'm happy to talk about it.
I imagine to some degree, cost plays a role in some of this.
Yeah.
And I don't want to make a long conversation out of discussing various regulations associated with who has to pay for what.
Sure.
But it's not, there isn't just this is one of the unique, I guess, even cancer's not, because cancer treatment's covered. This is one of the unique problems that women face, that is a medical issue that is no fault of their own. It's not something, a woman doesn't make herself infertile on purpose. It's not it's normal. It's socially and biologically normal to want to start a family, and it's the one
and essential. It's essential.
And essential, right? So essential to our existence. So it's the one disease or category of diseases that a woman may have to pay for out of pocket in a lot of circumstances, because it's not legislatively required for the insurance companies to cover it. And just the weight of that, just even saying that, sounds ridiculous to me.
Yeah, I think a lot of that is changing though. So about 70% of so we take all the major insurances, and because now there's a mandate in New York State for coverage, which just happened last year, about 70% of my patients are covered now. So I always say, people assume that it's not covered, but you always have to look into your benefits. We have 2 full-time financial counselors who all they do all day long is check benefits and counsel people on them. So about 70% of my patients are covered. If you're not covered, there's also more and more options for you out there now. So there's a lot of grants now that are out there. So there's a grant that's growing. It's called Baby Quest. There's the Tanea Cade Foundation. You just have to be hooked into the right avenues to learn more about them. SGF, Shady Grove Fertility, as an organization, finances are obviously we take it very seriously for our patients, and we have discount programs called shared help where, depending on income levels, you're eligible for up to a 60% discount on your services. We have military discounts. We have, something called shared risk, which is a program that's kind of our guarantee program for IVF or for donor egg, where if you qualify, you're basically guaranteed to take a baby home. And if you stop anywhere along in the process, you get all of your money back, which makes it a lot more powerful. So it's unique, but I think you're going to see that, more and more. And hopefully you'll see coverage more and more.
So you mentioned something which is a term that I hear quite frequently, and we're going a little bit longer today because this is our Mother's Day special. We really want to get this information out to people. We really want people to hear about getting pregnant and fertility. Again, we have Dr. Anate Brauer from Shady Grove Fertility joining us, with Dr. Davison from our very own Dr. Davison from Maiden Lane Medical. And again, our YouTube channel is youtube.com/maidenlanemedical.com. Please subscribe. So let's get back into the subject matter. You mentioned IVF. So what does IVF even stand for?
Right. So IVF is in vitro fertilization. It just means that you're fertilizing an egg and a sperm outside of the body.
Okay, great.
Yeah.
So when I was growing up, these were called test tube babies.
But they're dish babies. They're not tube
dish babies, right? Okay, so that's a really old term. Nobody says that anymore, and maybe that's how old I am. So that was 70s and early 80s, right?
Yeah.
Okay. So what would make you want to offer somebody IVF?
Right. So many different cases, right? Every case is individual, but let's say you have unexplained infertility and now you've done 3 IUIs. That's a good time to discuss moving on with IVF. And that's not an arbitrary number, right? That's based on data. So there's studies done looking at efficiency to pregnancy, comparing doing 3 IUIs and moving on to IVF versus 6 IUIs and moving on to IVF. And, there's no question that IVF is the most efficient route to pregnancy. In an unexplained fertility situation, you have to look at various different things. You have to look at age, you have to look at your ovarian reserve, and kind of like the way I look at it is in my unexplained population is I look at, okay, if I were to end up in the most aggressive treatment category, which is IVF, at what point is my success rate with that going to decrease? And that's what helps me evaluate timelines. So let's say a patient is 30 years old and she has a good ovarian reserve, everything's totally normal, and she's tried 3 IUIs and they failed. I would be more comfortable telling her, you know, your success rate is not going to change with IVF, even if you do 3 more IUIs and you wait a few months to do IVF, right? Because at the end of the day, she's young and she has a good ovarian reserve. Whereas my 38-year-old, I would be a little more inclined to kind of, after 3 IUIs, move into the IVF category, especially if they wanted more than one child. I'm always thinking about the second baby. If they get pregnant tomorrow at 38 with the first baby and they require IVF for the second baby, now they're going to be 40 when they come back, and their success rate is going to be even lower. So one of the biggest pluses of IVF is fertility preservation. Is if at 38 you can put 2 embryos in the freezer, if you use that embryo at 39 or 40 or 42, you're going to have the same success rate as the 38-year-old. So those are all the things I look at age, I look at reserve, and I talk to them about what's going to complete you as a family. How many children do you want? Are you going to be happy with 1? Do you really, really want 2 or 3? So that's important. So that's for unexplained. Other factors are tubal factor, right? If both of your fallopian tubes are blocked or damaged, then it's almost impossible. I don't want to say 100% impossible because crazy things can happen, but it's almost impossible for you to get pregnant without IVF, because IVF allows us to create an embryo outside of the body and then bypass the tubes and put it directly into the uterus. So tubal factor infertility. Severe malfactor infertility, meaning if your partner has a very, very low sperm count, those patients also benefit from IVF, because in natural conception, or even with IUIs, you need millions of sperm to potentially have one make it to the right place. But with IVF, we have the option of using something called ICSI for fertilization, intracytoplasmic injection, ICSI, where we take 1 sperm and inject it into the egg. So you don't need millions of sperm. You only need as many sperm as you have eggs. So those are categories that, you know, we recommend IVF for. Also, you mentioned endometriosis, right? So we know that with endometriosis, IVF is we're more inclined to move to IVF quicker, because we know that there's a higher efficiency to pregnancy with endo. So those are some cases in which I would recommend IVF. Or also, if you have a genetic disorder that you know you want to avoid passing on to your children, right? So all of our patients, and your patients probably get it too, have preconceptual genetic testing. This is testing looking at what we call recessive disorders. These are diseases, let's say one of them is cystic fibrosis, right? If you're a carrier for the genetic mutation that causes that disease, that causes cystic fibrosis, it doesn't affect you in any way, and it doesn't affect your baby in any way. But if you have a partner or a sperm donor who also carries the same mutation, the baby now has a 1 in 4 chance of having that disease. So you can do IVF and select embryos without the disease. And that's another reason why some people go straight to IVF, is to eliminate a genetic disease.
So we're going to do a whole week or 2 even on endometriosis. And I'm going to try to invite you back.
Yeah.
So that we can talk about endometriosis and infertility. We're kind of getting to a point where we need to wrap up a little bit, but
Sure.
I was hoping Dr. Davison would chime in on the endometriosis and infertility, but I think we're gonna have to table that topic, because it's a big one.
Maybe we'll make I think we should make a whole separate session.
Absolutely. Endometriosis and egg freezing is a huge
let's do
topic.
Endometriosis, egg freezing, endometriosis pain. Those are gonna be awesome topics. I have a question for you. Does acupuncture help with fertility?
Yeah. So acupuncture is interesting, right? So I'd say about 75% of my patients see an acupuncturist. I mean, not during COVID, but outside of COVID. Sure. If you
COVID
look
puncture. They'll have COVID puncture.
COVID puncture. So there was actually a pretty big paper published in JAMA that looked at,
which is, so everyone knows, is the
sorry,
Journal of the
yeah,
American Medical Association.
yeah,
It's like the stodgy old medical journal. It's great. It's sort of like a
yeah,
standard go. If you get published in JAMA, you're legit.
right. It's legit. That's the bottom line. And that looked at IVF treatment outcomes and acupuncture and showed that it didn't make a difference. But my view on acupuncture is I think it's a great tool for a lot of people. And if you feel like it helps you gain control of the process, if you feel like it relaxes you, I think it's very, very helpful. If you feel like it stresses you out because there's more needles involved and it's another appointment and it's more money, then I would avoid it. And that's kind of how I look at acupuncture. And for my patients, it helps a lot of them with relaxation and with feeling like,
sorry about that.
no problem. And with feeling like they're doing everything they can for their cycle. And there's very little risk involved. So that's my view on acupuncture.
So straightforward, and it's my understanding that acupuncture offers some general relief of anxiety associated with
Yeah,
the process, and I agree. If it makes
absolutely.
somebody feel more comfortable, then there's a good reason to do it. We lost Dr. Davison there for a second.
Sorry about that. This is
We had some
the
technical
true
issues.
Mother's Day episode here.
So right, so that's perfect. So Dr. Brauer, do you have anything else to add as a sort of button-up point that would really be great information for our YouTube audience to hear?
Yeah, I think the most important thing to know is there's always a way to make it happen if it's what you want, and you shouldn't give up on that. And wherever you are in the process, whether you're 26 and just like thinking about having babies, or you're 42 and are having this like epiphany of, oh my gosh, I want babies, it's always worth at least having a consult, right? It's so easy to do. Same with you guys and pelvic pain and endometriosis. We're all on telemedicine now. You can do it from the comfort of your own home. And I think it's important just to kind of get that information, and a plan is very anxiety relieving. So rather than, kind of driving yourself crazy about it, talk to a doctor, develop a plan. It doesn't mean that you have to go into treatment tomorrow. Just develop a plan. And I think you'll feel like you have a lot more control over the situation.
Dr. Davison?
I agree. If you're seeing us in the office, even for something unrelated, if fertility, even if you're 23, is on your mind, particularly if you have some sort of underlying cycle irregularity or pain issue, or even if you're just a healthy, regular person and fertility is on your mind, it's never too soon to ask us about it. It sometimes feels like the elephant in the room, but we're more than happy to engage. And, we have these newer technologies like egg freezing, which we'll talk about in depth another time, but there's a lot more that we can do. And even if it's just a consultation, just that relieving, just having the conversation and initiating a consultation can reduce so much anxiety. It's really worth it. Particularly, I'll just add that, some of us who practice in big urban places, or in New York City, women are delaying pregnancies, and it's really relevant to have these conversations just to think about it, even if you're not even sure what your own answers are. But having the conversation and alleviating some of that anxiety is really worth it. So we're happy to have those conversations at any point.
So Dr. Davison and Dr. Brauer are both moms, and I wish you both, because I know you're both working moms and you both work very hard and you both have young children. So I wish both of you a very, very happy and healthy Mother's Day. I thank you both very much for being here. To my wife and to my mother, I wish you both a very happy Mother's Day. And to all the people listening, all our YouTube audience, and all the people who are going to watch this video once it's posted, there's hope. For those of you who are moms already and looking to add to your families, or for those of you who are having difficulty, there's hope and there's light and there's always a way. And I think Dr. Brauer and Dr. Davison have answered a lot of great questions today, and we look forward to future telecasts. Once again, Dr. Brauer from Shady Fertility, Dr. Davison from Maiden Lane Medical. And please subscribe to our YouTube channel. Have a fantastic weekend and rest of the day, and please enjoy your Mother's Day. Thank you.